Voice is audible.
Okay, so today we will discuss about the aortic aneurysm, aortic dissection, and subclavian seal syndrome. So our first topic is aortic aneurysm, right? Aortic
Yes.
aneurysm. So aortic aneurysm is most commonly divided into the two types: thoracic aortic aneurysm and abdominal aortic aneurysm. So aortic aneurysm is most commonly associated with atherosclerosis, right?
Yes.
And the most common risk factor for the aneurysm, most commonest risk factor is a smoking. What is the most common origin of aneurysm? Aortic aneurysm is infrarenal. Okay, so the thoracic aneurysm is associated with cystic medial degeneration. Okay, the risk factor for the thoracic aortic aneurysm are hypertension. These are hypertension, bicust aortic valve. Bicust aortic valve is associated with pathology. And connective tissue disorder. Connective tissue disorder, Marfan syndrome, Ehlers-Danlos syndrome, right? So the aortic aneurysm mostly presentation is asymptomatic, right? It is asymptomatic. It is an incidental finding mainly. So the high yield association with thoracic aortic aneurysm is tertiary syphilis. High yield association, tertiary syphilis. So sometimes here they give you the presentation of the syphilis, mainly the tertiary syphilis. So the tertiary syphilis present with this is, can somebody identify this picture? Again, a high yield picture,
Gamma
The,
actually.
the gum.
right? So tertiary syphilis present with
Yes.
the gommas plus aortitis plus tabes dorsalis, right? Okay. It is also known as a neurosyphilis. So the high yield association with thoracic aortic aneurysm is tertiary syphilis, right? So tertiary syphilis, what will do the tertiary syphilis? It obliterate the vasa visorum. Obliterate the vasa visorum, right?
Yes.
Okay. So aneurysm, can anybody define the aneurysm? So aneurysm is basically the dilation of the art, dilation of the, it is a abdominal it is a aortic aneurysm. So it is a dilation of aorta. So aneurysm is a dilation of the vessel. So it is a aortic aneurysm. So it is a dilation more than 50% dilation of aneurysm, right? Okay, so this picture shows that the different areas of the aorta, right? So this one is ascending, this one is aortic arch, this one is descending, and this one is abdominal aorta, right? So abdominal aorta, most common risk factor is smoking, right? So when this abdominal aortic aneurysm, which is a triple A means abdominal aortic aneurysm. So rupture of the abdominal aortic aneurysm present with acute abdominal back pain, resistant hypotension, smoker plus 65-year increased age is another risk factor for abdominal aortic aneurysm. Smoking increase the risk of abdominal aortic aneurysm. These are high yield. These things are already highlighted. Smoking, age, right? So basically the aneurysm are the accidental or incidental finding. So abdominal aneurysm, if it is asymptomatic mainly, it is basically present with visible pulsation or pulsatile mass on the which area? Epigastric area of the abdomen, right? What is the most common origin of the aortic aneurysm? It is
Epigastric.
infrarenal, right?
Okay, can you please clarify, because you said something about epigastric, so between the epigastric and the infrarenal.
Sorry?
You said
Okay.
something about epigastric.
Epigastric. So the abdominal aortic aneurysm present visible pulsation on epigastric area, right? Stomach area, abdominal aortic aneurysm. It is a triple A, abdominal aortic aneurysm. And the most common origin of the aortic aneurysm is infrarenal, below the renal vessel, right?
Right, okay.
Okay. So again, so this is the typical presentation of the rupture of the aortic aneurysm, rupture of the abdominal aortic aneurysm, right? And the most strongest risk factor for the abdominal aortic aneurysm is smoking. Again, a very high yield stuff. Okay. Can anybody identify what is the pathology? What is the positive finding in this image?
Oh, that shows the dissection.
Dissection. It is a crescent
Mhm.
sign, right? So this is this one. So sometimes they give you this kind of the picture as well. Okay, the next is the aortic dissection. Aortic dissection. So the aortic dissection is basically the tear. So it is a tear in the intima of the aortic vessel. So this tear forming a false lumen. So this is a false lumen, right? This is a false lumen. Sorry. So this one is a false lumen, this one, right? So this one is a false lumen. So aortic dissection is a intimal tear. So that produce this false movement, this false movement. So this aortic dissection is classified by Stanford classification. So it may be the type A and it may be the type B. So this is again important. Why it is important? Because the treatment. So the type A involve ascending aorta, right? This is again ascending aorta. And type B involve descending aorta, right? So I will tell you why it is important. So the ascending aorta is basically needs emergency surgical management, right? While this type B Stanford classification of aortic dissection may be treated by medically beta blocker. First we give the beta blocker, then we give vasodilator. Why first we give the beta blocker? To prevent, if we give the vasodilator first, it will produce reflex tachycardia. So that's why we first give the beta blocker and then vasodilators, right? Okay. So how the patient presents of aortic dissection? It is a typical, again, it is the most common in the male, typically to 40 to 50-year-old, tearing sudden onset, chest pain that radiating to the back, and markedly unequal BP on R. So this is a typical presentation. And what is the most common? What is the most common site of aortic dissection? Most common site of the aortic dissection is above the aortic valve. Above the aortic valve to the and distal to the left subclavian artery. So above the aortic valve and distal to the distal to left subclavian artery. Right? So we will discuss the most common site of the origin of aortic aneurysm. What is the most common site of origin of the aortic aneurysm? Can anybody tell? It is infrarenal. What is the most common site of aortic dissection? It is above the aortic valve and distal to the left subclavian artery. Right?
Yes.
Okay. So these, if the patient is a hemodynamically stable, if the patient is a hemodynamically stable aortic dissection patient, then first, what is the best initial investigation? Is CT angiography. They give you this kind of the typical vignette and they want to ask about that the patient is hemodynamically stable. If the patient is a hemodynamically unstable, what is the best initial test? Is that transthoracic echocardiography, right? Oh, sorry, it's
Yes.
transesophageal. Sorry. Transesophageal echocardiography. So this focus on the words, like if it is a hemodynamically stable, then the best initial is the transesophageal echo. If it is hemodynamically stable, then it is CT angiography. If it is a hemodynamically unstable, then it is transesophageal echo. If it is hemodynamically stable, then it's CT angiography, right? Okay. Again, how will you treat that patient? The type A Stanford classification mean ascending aorta, mainly the this ascending aorta, right? So the type A mean and type B mean descending aorta involvement. What is a D-Back classification? The D-Back classification is another classification that used for aortic dissection. So in type A, ascending, sorry, type 1. So the type 1, ascending aorta plus descending aorta both are involved. But in type 2, only the ascending aorta is involved, D-Back classification. In D-Back type 3 classification, only the descending aorta is involved, right? So what is the treatment? If it is a type A Stanford classification, you will treat this medication plus surgery. If it is type B, you will treat medication and may need surgery, right? Just give me a minute. So markedly unequal BP in arms, right? Keep this thing in a mind. This is again a high yield point that is confusing with the subclavian seal syndrome, right? So what is the most common association with aortic dissection is a hypertension. Hypertension, which is the strongest risk factor. So the hypertension is a strongest risk factor for the aortic dissection. Hypertension is the strongest risk factor for the aortic dissection. So these two strongest risk factors is again a high yield stuff. So if you think that aneurysm, it is associated with atherosclerosis and strongest risk factor is smoking. If it is aortic dissection, it is associated with hypertension, which is again a strongest risk factor for the aortic dissection, right? So markedly unequal BP on both arms. What is the best initial investigation? Best initial investigation is chest X-ray. What are the finding on the chest X-rays? What is the finding on the chest X-ray? Very high yield. Widening of mediastinum. You find the X-ray on the Google, widening of X-ray. So this is widening X-ray is another cause, another finding on the X-ray for the aortic dissection. Sometimes they give you the X-ray of that, this clinical vignette plus chest X-ray. And you find on the chest X-ray widening of the mediastinum. Okay, let's move toward the subclavian steal syndrome. Subclavian steal syndrome. Okay, so the subclavian syndrome, the typical vignette is exertion of arm, produce pain, paresthesia, dizziness, and vertigo. Pain and paresthesia on arm, plus dizziness and vertigo. This is again unequal difference in the blood pressure in between the arms. But the presentation is a different. So if the patient present with unequal BP on the arm, the two differential. The first common differential is aortic dissection. And the next one is subclavian steal syndrome. So the subclavian steal syndrome, basically this picture. So in exam, they give you this picture. So what happened in subclavian steal syndrome is basically the reversal of the blood flow. Reversal of the blood flow. So what happened in subclavian steal syndrome? This subclavian vessel, look at this vessel, it is stenosis. So proximal to the origin of the vertebral artery, right? Vertebral artery. So if the patient doing the exertion of that affected arm, so what happened? That affected arm, the symptoms will be the pain, paresthesia. And why it's the dizziness and vertigo? Because there is a less pressure, this area, right? So here is a higher pressure. So blood from the opposite side, this right vertebral artery is moved towards the contralateral side, right? And in this way, the blood perfusion of the brain is compromised. So that's why patient present with the dizziness and vertigo, right? So again, what are the association of the subclavian syndrome? That are again a high yield. So association of the subclavian syndrome are the atherosclerosis, atherosclerosis, Takayasu arthritis, and heart surgery. So the modification of this kind of the picture you find on your Q banks question, right? Okay. So some difficult concepts related to the aortic aneurysm. Sometimes it's very difficult. Sometimes aortic aneurysm patient you will find on the chest X-ray tracheal shift. So people confuse about the tracheal shift. So why it is a tracheal shift? You don't need to know about why tracheal shift takes place in the aortic aneurysm patient, right? So, but you will confuse that you think that the patient is suffered from tension pneumothorax, but the presentation of this patient is typical this kind of pulsatile abdominal mass, acute abdominal pain, resistance, hypotension, right? So you will find that tracheal shift as well. Okay, so the management is dependent. So the abdominal aortic aneurysm management dependent on the size of the aneurysm, right? This is the super high yield concept. If the size is more than 5.5 centimeters, so what will be the treatment is surgery.
Surgery.
Surgical. So this thing is very important. If it is less than 5.5 centimeters, there is no surgery. One more thing is change in size. Change in size is again important. If the change in size is more than 0.5 centimeters for 6 months, then you will have to do the surgery of that patient, right? So again, the classification, their association are again a high yield, right?
Okay.
These pictures you will find a lot of these kind of the finding on your exams as well. Okay. Uh, Sometimes the aortic dissection may present as typically aortic dissection. Aortic dissection, where is aortic dissection? Okay, this is aortic dissection. Sometimes the aortic dissection presentation is this kind of, they present with upper chest pain, right? Upper chest pain, plus that pain is radiating between the scapula, between scapula. Okay, the most important thing is the unequal BP. So unequal BP, the most likely they want to ask about the aortic dissection, right? So on the initial investigation, initial is a chest X-ray. What you will find on the chest X-ray is a widening of the mediastinum. Next is CT. And okay, one more thing. Traumatic rupture of the aorta. What are the causes of the traumatic rupture of the aorta? It is mainly due to the motor vehicle accident, deceleration injury, right? And what is the most common cause of death due to the car accident? What is the most common cause of death due to the car accident? Is a basically traumatic rupture of the aorta, right? So if the patient comes due with the car accident and they're highly suspicion of the aortic rupture, what will you investigation you advise? CT chest or CT angiography? And traumatic rupture, what is the drug of choice for this patient? Traumatic rupture of aorta. Again, a high yield.
Surgical. Surgical.
No. The drug of choice is beta blocker, labetalol. This is confusing, but you know that. Beta blocker, mainly the labetalol.
Traumatic rupture treatment is beta blocker.
If they ask about the drug, pharmacologically,
Okay.
right? Yes, you are right that emergency surgical repair. But first you give the beta blocker like labetalol, then go for the surgery. USMLE love to ask this kind of the question as well. So they are giving you straight away the one option is a surgery, emergency surgery. This is not a correct option. The correct option is IV drug administration, IV beta blocker, then followed by surgical repair. Right?
Okay.
Yes. Yeah. So just a quick point.